This webinar is basically, we're looking at using evidence to guide decisions in both human and animal healthcare because we believe it is essential. But the volume and reliability of that evidence are constantly evolving. This webinar hopes to explore what evidence means across human and veterinary medicine, how it is generated, and where the two fields align or differ. We will look at conditions shared by people and animals and consider how cross-profession collaboration can strengthen the production of meaningful One Medicine focused evidence. Over to you, Mary and Rachel, and I will just stop sharing now.
Thank you, Jo. Thank you for that kind introduction, and wonderful to be here with you all and with Rachel. I'm really looking forward to this conversation. We've had a few chats already about all of this, and we could probably talk for 3 hours, but we'll try and keep it condensed down to half an hour. Just before we get on to the main conversation, I just wanted to set the scene with regards to One Medicine, in case this is a new concept to you. So thinking about what do we mean when we say One Medicine, it can mean slightly different things to different people. My approach and that of Humanimal is that we're advancing human and animal health care together through collaboration. And it's not at the expense of an animal's life. And we want to utilise and study naturally occurring disease. So there's a lot in there. It's a slightly different approach to things. And thinking about evidence, Rachel, if I can kick off the questions here then, and think about what do we mean by evidence? So what does that mean to you?
Yeah, it's a good meaty one. Thanks everyone for having me, and I hope we get some good chat going today, though, as Mary said, we can talk forever. So I think there's lots of different types of evidence that we use in clinical practice, whether that be in human healthcare or veterinary healthcare. And I think traditionally we often think about a clinical research paper, a piece of primary research, so a new study or finding. And there's plenty of that, and there's a constant and increasing amount of that produced each and every day in both sectors. And often people think that is what evidence is, it's a research paper. And yes, it can be that, but I think it can also be a number of other things. And actually, if we want to inform One Medicine and clinical care at the patient side, stable side, bedside, wherever we are, we need to consider multiple types of evidence. So as well as primary evidence in the research, traditional research framework, which are the new papers that are coming out all the time, we have secondary sources of evidence, and they're growing significantly in both sectors. So they're things like systematic reviews and evidence summaries. And I think they're hugely useful to clinicians because someone else has done the work for you to bring it all into one place. And I think it gives you an idea that we don't change practice based on one paper at a time. So we have those primary and secondary sources, but then I think what we also use to help contribute to the advancement of medicine is quality improvement data. So that is really critical. It tells us about how consistent we are in delivering care and what our quality of care is, but it also can teach us various things about variation in healthcare and the different ways of doing things, but also which actions in practice can lead to improvement. And then we have expert opinion, and we have so many gaps in our knowledge in the traditional sense from a research paper sense. And actually one of the joys of coming together within professions and across professions is sharing that clinical experience and understanding. And yes, it's biased, and yes, it's variable, but actually there's some really nice research methods out there now that are trying to combine our clinical experience, thoughts and opinions, as well as traditional data-driven science. So that's quite a long answer. There's lots of little spideys we could go along if we want.
There's so much to it, and different people will have different opinions, you know, whether it has to be that systematic review with hundreds of papers in there and lots of evidence, and the expert opinion. Some people have said to me, you know, they don't agree with that, they don't like that. But like you say, there's so much in there. And when we're starting with something like One Medicine, where we have so many gaps already, then I think there's scope for absolutely everything, isn't there? And as long as we acknowledge where those weaknesses are, and if there is a degree of bias there, what sort of areas, when I compare the vet world with the human world, I'm aware of the huge difference in the evidence. The human studies can have thousands of participants in them. We very rarely get that in the vet world. But, are there any areas that come to mind where there's an absence of evidence within some areas of vet and human medicine?
Yeah, I suppose I'm less aware of the holes in the human evidence base, but we may well have some people online that are very aware of those. But certainly all the work that I've done working with the Centre of Evidence-Based Medicine at Oxford, the Centre of Dermatology at the University of Nottingham, all in the human healthcare sphere, there are always gaps, and they're often based around very practical day-to-day things. Okay, so a lot of evidence gaps in veterinary healthcare are all the common clinical questions that we have in general practice. So for people from the medical sphere, a lot of our evidence is still driven from academic or specialist settings. Over the last 10 to 15 years, we're seeing more come from general practice settings. And I think that's really important. So the common things we often know an awful lot less about. Is that the right sentence? Anyway, we don't know as much as we do sometimes about the very weird and wonderful. And actually, all clinical presentations, whether they're around the prevention of disease or the prevention of suffering with chronic disease or whatever, there's always a variation in that caseload. So even if we have quite a big evidence base for something like diabetes, there still will be some patients that don't fit into any of the guidelines that we have or any of the papers we have because they're different from the other patients for some reason. And what research often does is sort of narrow down what we look at because it's very controlled, and we need an evidence base to cover some of those gaps. And new stuff, we don't have evidence on new stuff. So when Schmallenberg first hit the veterinary health sector, when COVID first hit the human sector, all we have is stories. So anything new has an absence of evidence.
Very true. And with things advancing so quickly, trying to keep up with all of that is incredibly difficult. If we could move on to think about how evidence is generated, and the ways it's generated in the vet world and in the human world, from your experience of that, what are the similarities or differences that you've come across in human healthcare and vet healthcare?
Well, it's the same, right? So data is data. Data are data, depending on whether you like to use the plural or not. But numbers are the same. We count similar things. We have similar research methodologies. We have a finite way of doing statistics, and that's true in human healthcare and veterinary healthcare. There's a finite number of types of data we can collect. The ways we collect them might vary quite a lot. But ultimately, the thing that differentiates us really is the population study. I always say to people in the medical field, my patients are my patients just like yours are. Mine just are a bit more hairy or feathery and walk around on four legs rather than two, which can work to their advantage because, being a biped is quite hard. But so I think the way we generate evidence is similar. It should come from a clinical question that matters to patients and the clinicians involved. And we almost always have a carer, so a client or a pet parent, whatever people want to call that. But often human patients arrive with a third party, an advocate or a relative or someone. So we generate evidence from the same kind of sources. And because we have very similar research questions, our research is very similar. A lot of the methodologies I've adopted over the last 15 years for my research are stolen with pride from someone else and copied and adapted. And I find the medical research, evidence-based healthcare researching field really open and interested in how we can pick up what they've done and help move it forward.
Yeah, and there's so much overlap in the conferences I've gone to from the human side of things. It's fascinating because you
Yeah,
can just see the similarities and the differences, you know, that there are
yeah,
differences that we have to acknowledge. And I suppose when I first started out teaching evidence-based practice, I was completely quantitative. Everything that I did was numbers. I like numbers. And this qualitative studies, oh no, that's not for us. We don't do that. Um, and I have changed my mind over the years and actually found myself now publishing qualitative studies because our animals come with owners. You know, we have that lovely combination in the vet world of dealing with the animal and working with the person that comes with them. So we can learn from the carers for our animals effectively. I won't call them our patients as well. And compare things with the human medicine world and the patients. And there's so much that we can learn there. What do you think about the clinical trials question? Because it's something I still haven't quite got my head completely round how the vet world can advance in this area. You know, the NHS is much more structured when it comes to clinical trials to generate the evidence. Vet world's maybe a bit more difficult. You agree or
yeah.
disagree with me on that one?
If we're talking truly about trials and not scientific studies, I think
Mm.
we we often organise our populations differently to human healthcare. So, you know, a herd of cows is a herd of cows, and it can be 330 or 3,000. But if we're talking particularly about trials, so we're looking at treatment efficacy, is A versus B, or are we trying to see whether a test A is better than a test B? Generally, our trials are smaller. We don't have yet clinical trials units like we do in human healthcare. And and we have to be careful with trials because they give us an answer. It's not a definitive answer, but it's another jigsaw puzzle. And I agree with you about then needing other types of research to embed the findings from trials. Where I look to learn a lot from human healthcare, and I spent quite a bit of time with people setting up and running clinical trials in human healthcare and clinical trials units, is if we think about new products coming to market, whether they be diagnostic tests or treatments, we don't have a structure that means we then do a very large scale, real life pragmatic trial that can move us on from when a drug is licensed. It's the same more or less in both human and veterinary healthcare. We know so much, and we have the information required to get that product to market set by our regulatory requirements, which are obviously different in the two sectors. But then often, not always, but often if this product or device is of use, we think in human healthcare, it will go on to these big, large-scale trials. We don't have those yet. We need them. I think what we are seeing over time is that the quality of the trials, the size of the trials, because size doesn't always matter. There's no point having a big trial that's rubbish. Might as well have a well-done, smaller trial. But we are seeing bigger and better trials, and certainly in my work now, or not all of the questions, like in human healthcare, a lot of the questions are about efficacy. People want to know when something's new or when you've got A and B, which one is better for this patient. So we need more trials. And I think they are possible in veterinary health.
Yeah, they are. And I suppose students coming through now are being taught much more about evidence-based practice than certainly in my day. So they're more familiar with all of these processes and research methodologies and how to critique a paper and evaluate things. And I would hope from that be much more willing and enthused to contribute to that, to build
Yeah,
all this information.
I think so. Much more in the mindset, the evidence-based mindset of that our science isn't complete. Okay, you know, if we'd done all science, we'd have all given up and we'd have nothing to talk about. The whole point of science is it's progressive and it keeps going, and that's what's great about being in healthcare as well as relieving suffering. We're moving the world forwards, and we are all scientists. Doesn't always feel like that, but we are. But one of the things we need to do is recognise what we don't have as well as what we do have if we're being an evidence-based clinician. So trials are only good for answering efficacy questions, really. If we want to know about risk, we need to do other types of studies. And I think more people are realising that. So I think there is definitely an appetite for doing more of this. Most people that I've worked with over the last 15 years or so when I've been doing evidence-based healthcare if you do something with them, they want more, not less. So it's there.
Yeah. Yeah, they do. And evidence is so easy to get to now as well. You know, I remember the days of having to go to the 9th floor of the library and go and find a paper and go and photocopy it. And now we can just sit here. So we have so much evidence. I wanted to move on to think about different species, because this is a question that comes up quite a lot about human medicine, veterinary medicine. Are there similarities? Can we learn from each other? How similar are animals to people? And when we were chatting, you know, we were discussing some of this earlier in the week and thinking about, well, what are the similarities? What are the differences between different species? And it got me thinking about my background. I used to be a dermatologist, and when I was doing my PhD and my training, I spent a whole load of time going to human medicine conferences, dermatologists, learning about atopic eczema in people, the similarities, the differences, and all that side of things. And then when you think about it in animals, dogs, cats, they're not the same. Dog skin is completely different to cat skin, and they can present with allergies and atopy in different ways. And so it got us thinking about that then. So from your perspective, what do you think are the similarities between humans and animals, but also what are the differences for generating the evidence?
So unless we look for the similarities and differences, we don't know what they are. So, you know, when we do a search, we can find absolutely zero in pigs or sheep or cows or cats or whatever it is that we're interested in. We're searching for the evidence base. We'll always have a cheeky look at the human literature as well, because sometimes you will find something that is helpful. And equally, if I'm working in feline, if I can't find anything about cats, I'll have a look at dogs. I know the difference between cats and dogs. I think I know most of the differences between humans and cats too. But it's worth having a look to see what is helpful. I love being a vet. I think it's amazing what we do. I love working across species. So I was a feline medicine specialist at one point, but now I do all species, and that's when my career started. And I think that cross-species learning is critical, because often we won't have come across disease A in this species before, but if we look, we've seen it in something else. But also it's that variability. So atopy, skin disease is a good example, so is diabetes. It's not one disease. And so if we look at the variation of presentation of atopy in humans, dogs and cats, there will be some overlaps in that. And there might be a really weird presentation in human healthcare of type 2 diabetes or something that is very, therefore, similar to actually the kind of cats that we see all of the time. And yes, they're obligate carnivores. They're completely different from us omnivorous bipeds. But I think there is something that the human healthcare sector can gain just in the way that we do from them. And I mean, variability is key in healthcare. You always come across the case that doesn't fit whatever protocol or guideline that you have. And I suppose the other thing that I didn't say earlier is I think it's important to think in a one medicine way, because our clients are doctors' patients. And so when I'm talking about hypertension, when I'm talking about allergy, when I'm talking about vaccination, they will have had those conversations also with their GP or doctor in hospital. And I think understanding that people get their health information from lots of places is key. So a person might be newly diagnosed hypertensive, but they might have a hypertensive cat at home and know exactly how to use a blood pressure machine.
Exactly. That's a really good analogy there. And I think it's that recognition of we are all animals, whether, you know, human animal, canine animal, whatever, we're all animals, and biology, physiology, anatomy is so similar. But yes, there are obviously differences as well. And it's that learning from each other. When you mentioned there about the, you know, the weird and wonderful and the rare things, you were reminding me about case studies. So we didn't really chat about where do they sit on the evidence and the generating the evidence, because I've kind of seen case studies go from something that was very popular to something that some journals wouldn't publish. And now are they getting more popular again? Do they have a place, a case study?
Oh, we talk about this all the time, and I know we talked about it earlier in the week, and where do we go here? So like all types of evidence, we need to understand what they are and what they can tell us. So a case series, or to me, a case study, is telling a story, and stories are really powerful. Are they a good source of evidence for telling us the risk of a disease? No. Or the prognosis of a disease? No. Or the efficacy of a treatment? No. Are they good at describing a clinical presentation and a possible outcome of that individual? So I think they do have a place, so long as we don't take them as a truth of fact, like this worked in this dog, therefore it's going to work in every dog. We don't know that. Equally, if we have a story of a side effect from something that happened in this one dog, we don't know that it was caused by that drug. And true in humans too. So I think we can use them, and stories are a great way of explaining things to clients or to fellow clinicians or the non-research audience. But most diseases start with a story. I mentioned Smallenberg and I mentioned COVID. When a new health challenge comes on the horizon, whether that be a disease outbreak like those two, or whether it be a new presentation of canine atopy or human atopy, or whether it's a new tool that actually could transform healthcare, all we've got to start off with is a story. And paying some attention is critical because, as we all know, what happened with the COVID pandemic, it started with stories of infectious pneumonia in Wuhan, and it turned into something. And you watched people notice, and it's really important that we notice. It's really important that we don't overreact, but sometimes a story is all we need. We don't have any efficacy RCTs about whether diuretics work, thiazide diuretics. We know they work, so you don't need to test that. The story was, we've tried a long time ago, I think it like yonks ago, in human healthcare, it worked for congestive heart failure, so we carried on. We don't have any trials in veterinary healthcare either. We just looked at what happened in humans and went, we've got that, we'll have some of that, please. And that's really good.
Yeah, there is so much there, and you are just making me think about, that dipping into, I do that all the time. I dip into human medicine and I go look and get the information from there. And maybe it's time now that, the medics we can return the favour, so to speak. The medics can learn from us as well. Thinking about collaboration then, and moving on to how we can work together, how do you think the vet world, the human healthcare world could collaborate more and generate the evidence for one medicine?
Yeah, I think that's a really good question. I think there's a number of different layers to it. So as fellow clinical researchers, we can always learn loads about how to do it. So research methodology and different sources of data and how to deal with those data. So, for example, we're increasingly, thankfully, in veterinary healthcare using electronic patient records a lot. And they're used differently in different healthcare settings across veterinary, across human healthcare. And I think we can learn massively about how we can most effectively use that naturally generating clinical data. And that can be around language processing tools, AI tools, about how we extract information. But, there's that, but then there's also how we use data. One of my favorite publications is a tool for critically appraising cross-sectional studies, because we at the Centre for Evidence-Based Veterinary Medicine were wanting to do systematic reviews of observational studies. Now that they are done increasingly more and more, but they were done less at the time we started. So there was a lot, it was growing in diagnostics, there was a lot in therapeutics, but there was little when we were trying to look at risk. And maybe because of the way we manage populations, do a lot of preventive healthcare, particularly in farm sector, we possibly were doing more with observational studies. It might also, because we have less trials, don't know, but actually some of the questions are about prevalence, incidence, risk. And so we realised there was no critical appraisal tool for cross-sectional studies, so we developed one. We developed it with Hal Williams in the Centre of Evidence-Based Dermatology, because we had a need, and it's published in BMJ. It's not published in the veterinary literature, and it's used in many different types of systematic review with many diseases, with many species, because a cross-sectional study is a cross-sectional study. And I love that we did that. So there's definitely the methodology piece and the synthesis of evidence, because we're still learning all the time how we do that. And then, I mean, there are some clinical things too. So certainly in the veterinary dermatology world, there's some good relationships, I think, with the human dermatology world. Similarly, in epilepsy, some aspects of sort of neonatal pediatrics too, you can start to see people coming together. And I think my PhD was around injection site sarcomas in cats, which was a putative risk factor for feline vaccination, and not risk factor, a potential adverse event. And was vaccination a putative risk factor? I don't think it is. But it was interesting because it was at time there's a lot of worry around MMR and autism. And I, again, worked with that community around the fear of vaccination and actually what studies we need to talk about this properly, because we have very similar problems, some of them social, some of them clinical.
There's the clinical side of things, there's the disease aspects, you know, there's the cardiology, the diabetes, the renal disease, but there's also the human factor side of things, and whether that's our owners and patients or that's the actual clinicians as well, because we have so much similarity between the vet world and the human medicine world, you know, dealing with things that go wrong, the emotional side of things, the stress side of things. There is an awful lot of overlap, isn't there?
And there's a lot of threats as well. We were talking just then that I went to a great conference in Oxford, human healthcare conference called Preventing Overdiagnosis in September. It was great. But the last plenary was one of my favorites. It was a little panel, and this doctor stood on the stage and talked about the health influencing. So what's coming at us from social media, online, the media, and your client presents with all of that in their head now. And you're right, you were talking earlier about how there's greater access to evidence. There's also greater access to thinking of a polite word for the other stuff that is thrown at us that's maybe not so based in science and truth. We all face that. So he was talking about being a cardiologist and asking very open questions about what people were taking. And he didn't mean medicines, he meant supplements, he meant testosterone, he meant all kinds of things. We see that in our setting too. And that voice is very powerful. It's like the marketing voice, the social media voice, the influencer voice is very powerful. And I think it's critical that the human healthcare professions and the veterinary professions work together in some way to combat that. Because, you know, so many people come in and say, I'm on this and this for my that and that, therefore Bertie the dog is on this and this for his that and that. And you're like, okay, great, thanks for sharing. Now I can try and work out how that might affect what I do. And, you know, I think we have the same challenges in that way. And that's one of the biggest challenges at the moment. If you look at the media this week, what people think of prostate cancer, you know, does that matter more than actually the scientific rigor behind screening tests? And we have the same problem. We need people to understand what screening is, what the potential benefits and harms are, and how health policy can be affected by it. I think it's just the same.
Absolutely. The screening side of things was in my head as well. But there, you know, the potential harms to people if they get a positive result, but we have the potential harms to the owners if we do the same things, and the interpretation of it. Absolutely. So many similarities. I suppose we'd better draw this together, because I'm sure there'll be some questions there for us in the chat. But, you know, when you and I were chatting earlier, we were thinking about the fact that there is so much evidence out there, but there are also so many gaps as well. And by coming together, we can learn from each other, and we can hopefully fill some of those gaps, and we can take forward healthcare for humans and animals. And I was wondering how to phrase that, and all I could come up with was, we don't know what we don't know. And I hope that makes some sense, and that by coming together and having these conversations, we will find out what it is that we don't know, and bring it all together. But, you know, it's only by sharing the stories, sharing the evidence, learning from each other. I think there is so much we can learn from both professions, that we can generate new knowledge and advance healthcare for all. So thank you, Rachel. That's a fascinating conversation. As I said, we could have kept going an awful lot longer. But Jo, we will pause there and see if there are any questions.
Thank you.
So,
thank you, Mary. Thank you, Rachel. That was informative and enjoyable, and I hope everybody here really enjoyed it.